there, my name is Elaine Ziner, and I'm thrilled to be talking to Dr. Kolski, a vascular specialist at Providence who has been at the forefront of international cardiology treatments. Before we get started, we want everyone to know that this video is for informational purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. As always, seek advice from your physician or another qualified health provider with any questions you may have regarding a medical condition. Now, onto our topic for today, which is transcatheter aortic valve replacement, or TAVR. This is an innovative treatment that extends the life of patients with aortic valve conditions. Today, we're going to talk with Dr. Kolski and get an expert perspective on what TAVR is, who it can benefit, and his general experience as a clinician in the field of heart and vascular patient care. Dr. Kolski, let's start off with learning a little bit about yourself. Can you tell me where you're based and how you got into the field?
Sure. So my specialty is, basically treating cardiovascular disease. And I'm an interventional cardiologist, which means that most of my practice is related to doing procedures to fix cardiovascular disease. My office is based in Orange, California, in basically the heart of Orange County. And I got into specifically the structural heart part of interventional cardiology due to just the novelty of it, and there was just a real void of doctors taking care of these types of patients. I started out doing more peripheral vascular work, which kind of goes hand in hand with the structural cardiology. So it was sort of a natural transition for me to move from the vascular space to the valve space. So that's how I ended up here.
Okay. And then can you tell us a little bit about what your approach is to patient care? I think, even doctors who are treating the same conditions and doing the same procedures often bring a little bit of their own approach and own perspective into it. Can you tell us what your approach is?
Sure. I'm a big proponent of patient-centered care and really making sure that patients are making informed decisions. So our approach here at St. Joe's is a team approach. So every patient that ends up with a valve procedure is met with a cardiothoracic surgeon who does open heart surgery, one of our interventional cardiologists like myself, and typically a radiologist is involved in their care, and some even nurse practitioners and other aspects of healthcare like anesthesia are sort of factored into it. I think from a patient perspective, you really want to have all the options discussed, the pros, cons, the benefits of each approach. And I think when you sort of involve the patient into that team approach, everybody wins, and patients are really able to make informed decisions which end up benefiting them in the long run.
Mm-hmm. Well, I'm sure that helps give them confidence and comfort too in the choices that they're making, to have access to those specialists who can ask them the questions.
Well, I think, we've come a long way in medicine, and where it used to be someone would come for an opinion and you would just tell them what to do. Patients are much more savvy. Their family members have done research. They know people in the field. They know somebody who works for Edwards Life Sciences. They know somebody who works in somewhere else in the country. And so people are coming to the table with a lot more knowledge, which personally, I think is a big plus, because it ends up being a much more informed decision. So.
Mm-hmm. Well, that's great. Now, let's dive into the actual procedure. Can you tell me what TAVR is and how it's different from other procedures like open heart surgery?
Sure. So the way we used to treat aortic valve disease. So essentially, the aortic valve is the main valve that goes from the heart to the rest of your body, and your heart has to pump a certain amount of blood, every minute for you to maintain a normal life. And
Mm-hmm.
as that valve becomes blocked, your cardiac output goes down, and you develop symptoms of heart failure and low cardiac output. The treatment is mechanical. There's no medication that can fix this condition. And it used to be the only way to do it was with a sternotomy or a surgical approach, where you open the chest, open the heart, and open up the aorta and replace the valve by removing the old valve.
Mm-hmm.
In patients as they got older and sicker, that condition, sometimes you're trading a surgery which is quite involved the risks associated with that are much greater. So this approach was developed really for initially patients who were inoperable. The procedure that we do is typically done through the leg or arm. We go through the blood vessel and we replace the valve essentially from the inside. We typically will essentially crush the old valve as we expand a new valve in its place. And this started in really the most severe and inoperable cases. And as we've done research and sort of perfected the techniques and improved the technology, we've now expanded this technology to go to now even low risk patients, and as an opportunity to trade off having to have surgery versus having to have a minimally invasive procedure. The main differences are the recovery time is much less with the transcatheter heart valve replacement because you're just going through a small incision in the groin.
And about how long is that recovery time compared to more
Surgery?
the traditional open heart?
So in the transcatheter heart valve replacements, our length of stay, our average length of stay is 24 hours. So patients typically go home the next day, and then are typically recuperating nicely at home. I mean, they're walking, they're doing their usual activities, and then getting back to usually kind of some type of exercise routine within a couple weeks. We've even, because beds have been so constrained as of recently, done patients and discharged them the same day. So really the recovery time has dramatically decreased. And in the typical open heart surgery type of case, the patients would be in the hospital at a minimum of 4 to 7 days. So the recovery time, and then the recovery time afterwards would be about 6 weeks before patients would feel sort of back to their typical exercise routine, et cetera.
You talked a little bit about how TAVR was first developed for patients who were inoperable, and then it kind of became more available to kind of everyone who needed or would benefit. Have there been any other innovations, or how long has the procedure really been around?
I would say in 2014 was a big shift into sort of expanding the technology outside of the initial sort of study centers. And as the data has sort of, we've done clinical trials in every group, every risk population, low risk, intermediate risk, and high risk. The FDA basically, once we present the clinical trial data to the FDA, sort of determines if it's approved for those patients. And then centers like Medicare and the insurance companies then will say, well, then, once the FDA sort of approves it, we'll then consider coverage for it. So it becomes a coverage issue as well. But from the standpoint of, it's grown exponentially since 2014. And I think the high volume centers like Providence, St. Joe's, where we're at, have really, been able to expand this to patients who we previously thought would never have been able to take, to undergo a procedure, including patients that have had previous valve replacements. So second valve replacements.
So in this growth, is it becoming more and more common compared to other ones, or is it like, how does it kind of fall in that spectrum?
Yeah. So currently in the United States now, transcatheter valve replacement has exceeded open heart surgery as far as numbers go for treating aortic stenosis. And this is a relatively recent phenomenon. But I think the growth is such that, patients, because they're able to kind of do their own research, patients would prefer a minimally invasive approach if the trade-off is not that they're going to have an inferior procedure, so I think patients generally have been driving this shift in care.
Well, it certainly sounds like there are benefits for those that are good candidates for it. You've talked, it's minimally invasive, there's shorter recovery times. What are some of the other benefits that come along with it? Since it's minimally invasive, is there less pain? Those types of things?
Yeah, I mean, I think all of those, everything that goes along with not having to have an incision are, less wound infection, less pain, a quicker recovery time. And I think it really, this is not a one size fits all approach. I mean, that's why it's so critical to have a team that knows what they're doing. Every patient has a CAT scan. We look at the valve anatomy. We look at other factors like, whether they would need bypass surgery for blocked arteries. And the patient really needs to get the right operation, not just, the operation that you do. So there are definitely patients that we still recommend having surgery for, if we think that's the right operation for them at that time. So I think
Mhm.
the critical thing is not necessarily, I think in the situation where there's a tiebreaker, you go for sort of the minimally invasive approach. If there's a situation
Mhm.
where one favors the other, then you definitely would try to persuade the patient into having the right surgery, not just the one that you're doing.
Mhm. Well, it sounds like that patient-centered care is really helping deliver that tailored, personalized care to make sure they're getting exactly what they need. So it's
Yeah.
great. So you
Hang
talked
on one
about
second. We'll have to pause for a second.
sure,
Okay. Yeah. Okay.
sure. So you talked about how the valve is replaced through the vein. What
Through the
is the
artery.
new valve? The artery. Sorry.
Okay.
The it's the valve is replaced through the artery. What is the new valve made of?
Let me show. I can actually show you a couple here.
Oh, that'd be great.
These are the actual valves we use.
Oh, wow.
So this is one of them. So I think you can kind of see that. This is
Mhm.
a porcine, meaning a pig pericardium that's basically sewed onto the stent frame of this particular valve. This is one of our what's called self-expanding valves.
Uh-huh.
And this is a bovine or cow pericardium that's hand sewn onto a stent frame that has a little skirt on it. So this is our balloon expandable valve. So there's a
Mhm.
couple that these are the two commercially available options in the United States. And both of
Mhm.
the stent frames are some component of a metal alloy like nitinol, which is
Mhm.
easily compressed so that it fits through the artery and then expands
Mhm.
predictably. So
So that was my next question. That looks a lot bigger than an artery, so it
yeah,
compresses down and kind of collapses through, because is a catheter then snaked
correct.
through the
Yeah,
artery?
exactly. Yeah, the catheters go up through the artery and the femoral artery, and one type of the artery is sort of the valve expands in place, and the other one it's crimped onto a balloon, and then when the balloon
Mhm.
expands, it expands the valve. So yeah, that's
Mm.
how we're able to deliver it through a small person's leg.
Mhm. Well, that's fascinating. Um, so how does TAVR impact a patient's quality of life? What are some of the symptoms they're experiencing before surgery, and then what are they able to kind of regain or reclaim after the procedure?
So what's critical to understand is patients that develop symptoms from aortic stenosis, which is the condition that we're treating, their life expectancy is less than if they had metastatic pancreatic cancer, meaning
Oh,
about
wow.
half of patients are no longer alive at 2 years. So this really is a life prolonging and saving procedure because essentially when you treat the patients, they're cured of the problem. In addition, the symptoms that they experience, so congestive heart failure typically is breathlessness, fatigue, congestive symptoms, dizziness, chest discomfort, all those things that go along with when the heart is just under a sort of tremendous pressure. When you relieve that pressure, those symptoms improve. So from the standpoint of impact and clinical impact in medicine, this is one of the higher impact type of procedures that we can offer patients.
It's always so fascinating for me to hear and learn about all the things that are possible with medicine and science these days, especially procedures like this that, what was it, 10, 20 years ago? It doesn't sound like it was necessarily available to
Yeah.
everybody.
When I finished my fellowship, that we weren't doing this procedure, so a lot of us had to learn this after our training
Oh,
programs, and really, we really had to push ourselves to kind of get out and figure out how to do this because, as it became apparent, this was going to be a paradigm shift in the treatment. You have to really catch up to the technology. So it's been a fun 5 or 6 years.
yeah, that must be an exciting thing as a physician and a surgeon to learn about these new things and be able to deliver them to your patients.
Yeah, absolutely.
So, you've talked a little bit about talking with patients and delivering the patient-centered care, but what are some other things that you talk to your patients about when you're counseling them about this procedure?
I think, from my standpoint, it's really, when I first meet patients, I tell them, look, this is, it's a team approach. So, be prepared that you're going to have to get some studies and you're going to have to talk to some other doctors. People, when they meet me, want to get it done the next day. And I
Mhm.
tell them, like, let's pump the brakes, let's get all the information before we can really make an informed decision. And I think that's going to be frustrating for patients because nobody wants to wait if they're feeling poorly to get themselves, sort of fixed. But I think, you really have to manage expectations. This doesn't cure every possible, I tell patients that, you know, that have sleep disorders or have other issues, it's taken a lifetime for this problem to sort of creep up, and it doesn't, they're not going to feel necessarily 100% better the next day. They have to sort of get reconditioned and everything else. So, it's a little more than it's not a one-stop shop. They have to do the
Mhm.
cardiac rehab. They have to still maintain good nutrition and good sleep and everything else. So I think, it's really managing all the external factors that the patient has control over that I try to emphasize when we first talk, that it's not just,
Mhm.
we put the valve in and it's a miracle the next day. But
Mhm.
it's at the same token, I saw a 97-year-old woman in the office yesterday who'd been feeling bad for 20 years. And literally her family said the next day she was, you know, a different person. So I think those are the satisfying things that happen too.
Yeah, that's great. So you mentioned the cardiac rehab. So the patients who have this procedure still need to go on and do cardiac rehab and work with the physical therapist, or kind
Yeah,
of what did that recovery
exactly.
look like?
Yeah, because patients naturally become deconditioned that have this problem, and in order to recondition your skeletal muscle and recondition your lungs and everything else, I personally like the supervised exercise program that we offer here. I think it pushes patients safely. They have the confidence that they can kind of push it a little more than they might not do at their home on their own treadmills or whatever.
Mhm.
So I recommend it for 100% of my patients. The younger patients that already are pretty active will sometimes do it for a couple weeks and then sort of realize they can get back to it on their own. And then the older patients who are a little less sure of themselves will stay with it. And I have patients that pay out of pocket after a year that still do cardiac rehab because they enjoy the interaction with the nurses and the staff and everything else. So I think for me, it's
Mhm.
100%. I recommend it and offer it. And it's up to patients whether they sort of follow through on it. But I would say the vast majority do because they feel better with it. So.
Mhm. Well, it sounds like this procedure is something that can help a lot of people. Is there an ideal candidate? I mean, what do kind of people need to know to think, well, you know what, this might be the right procedure for me, or, well, that sounds really interesting, but, are there certain things that might not make it
From
in the
our
best?
standpoint, that's what we discuss in I
Mhm.
I really there's no one that's not a candidate,
Mhm.
and I would say really just a experienced heart team should give you the best opinion because there are young patients that are better candidates for this procedure, and there are older patients that are better candidates for open heart surgery. And until
Mhm.
I see the anatomy and look at every sort of factor, I just can't give an opinion on because we've done this procedure in patients as young as 40, and we've done this procedure and we've recommended open heart surgery to patients as old as 90. So I think,
Mhm.
it's just one of those things where it really is based on the interaction with the heart team, which is critical. We
Mhm.
have phenomenal surgeons here who are part of every procedure and part of every consultation. And occasionally we disagree, but when we disagree, we always, the patient will typically win in that scenario because we'll find some common ground. So I think, from our standpoint, that's a big benefit. So.
Mhm. Well, this has been fascinating talking with you. I really enjoy speaking with you today, but I don't want to take up too much of your time. Is there anything else you want people to know about this procedure, or anything we haven't talked about that you would want to add?
No, I would just tell patients, when you're entertaining having a procedure on your heart, is to find an experienced center that does a high volume, and find experienced operators that I think you're just the more experience the folks have that are taking care of this, condition, I think they're just going to be in better shape. And I would recommend anybody that has questions about it, seek out a local center that has a lot of experience here. And at St. Joe's, we've done over 700 of these procedures in the last few years. So
Wow.
we're in that category of, I think, providing excellent care to high numbers of patients at a real high level. So
Yeah, well, that's great. That's great that patients have you as a resource in the community and outside of it even. So, well, thank you so much for your time. I really appreciate it, and I will let you go get on your day. I'm sure you are very busy today.
all right, I appreciate it. Thank you.
All right, thank you so
All right.
much.
Okay. Bye-bye.